So first off, thank you everyone who's able to join us today for our little town hall that we have on the Omicron variants and what's going on with that. So my name is Ricky Ashby. I'm a MD PhD student at the University of Florida. I graduated with my master's in public health back in 2016. And one of my clinical mentors today, Dr. Frederick Southwick, is a board certified infectious disease specialist and has had decades of publications in the field of infectious disease and continues to contribute as a UF faculty and current practicing physician. So we're a part of the Bright Care Alliance, which is essentially a collaboration of medical professionals as well as patients and various other stakeholders in the healthcare system who are trying to advocate for evidence-based changes to essentially promote proper patient advocacy and patient rights. And if anyone has any questions about that, we'd be happy to take them up after the recording. But for now, we're going to be addressing a lot of questions that people have, and we'll be answering them to the best of our ability based off what we have. And if we go to the next slide, so we can get to what many of you already know, but some may not, the origins of the Omicron variant, which is out of South Africa. So although it was first detected in South Africa, it's believed that this has been an ongoing evolution that's been throughout Africa. But South Africa happens to have really great surveillance. That's probably one of the reasons why it was detected there first. There's a lot of theories as to what caused it to mutate to the degree that it was. Some theories include, the replication rate in immune-compromised individuals who are HIV infected may be higher. And there are also a lot of individuals, a lot of populations in Africa that unfortunately have not had the ability to get vaccinated yet. So there's a lot of things that are currently being investigated in terms of how this variant got to evolve so fast. And where we are right now is about almost 2 years into the pandemic. So you can see all the different surges we've had and the general shape and the trend that they have. The first few strains that we had, which were later named Alpha and Beta, they kind of competed with one another, and then came along Delta, and that overtook all of the others very, very quickly because its R0 value was extremely high. When I say R0, I'm saying the transmission rate. And as you can see with Omicron, you don't really see any rounding with that increase. It's extremely steep, which should concern us because that is usually an indicator of where it's going to peak. Its doubling time has been predicted to be as small as 1.5 days nowadays. So if we go to the next, and this is in South Africa, by the way, this data. If we go to the next slide, we can see that local transmission is already happening in multiple countries around the world, including the United States, Canada, Australia, India, and Europe. And in many other countries, there have also been Omicron infections detected in travelers. So we don't know how this will change in the future, but one thing is for sure that local transmission is already taking place in the United States. And this is from the CDC that shows how many cases they've identified so far. And the new US cases are very quickly becoming mostly Omicron. So we expect that Omicron is very quickly and very rapidly become the dominant strain in the United States, just based off the initial data that's going on. And here in Florida, there are already confirmed cases. And just to give an idea that this is going to happen in the United States, most likely. We have some data that we were able to get from Massachusetts that just kind of shows the projections of where this is going. These spikes, this very exponential growth that we're seeing, the transmission rate, is likely going to happen in the US, just like it did in South Africa. This is an example of what it looks like in Massachusetts. Essentially looks very similar to those previous graphs that are just showing very rapid growth that indicates just how infectious this virus really is.
Great, Ricky. So the question is, why is this virus so much more infectious? And in order to understand that, we really have to understand a little bit about the virus itself and how it works. And first of all, you've all heard now of the spike protein. That's the little red knobs, also some knobs, and they bind to host cell, bronchial epithelial cell ACE2 receptors. and they bind with high affinity to these human cells. Once they bind, the virus quickly enters into the cytoplasm of the cell, where it has a replicase that starts reproducing the RNA, and that RNA, actually part of it transcribes to proteins for the virus and continues to replicate the RNA itself of the virus. And then it combines the RNA in the nucleosomes with the proteins from the endoplasmic reticulum. It forms into a vesicle, and then it's excreted out of the cell and produces intact viral particles that then are capable of spreading to other cells, as well as populating your saliva and sputum. The original virus took 10 hours from start to finish, and usually produced 100 virions per cell. But then came along the Delta variant, which was what we're dealing with right now, and is still dominant in the United States, but not for much longer. And that variant had some mutations actually in the binding site of the spike protein, and this T478K increases affinity for the ACE2 receptors. And the P681 mutation actually affected a furin cleavage site. In order for the virus to enter, it must be cleaved at the furin site. And if you can cut that virus more quickly, it gets that site more quickly, it gets into the cell more rapidly. The consequence was that rather than the original wild type infected 2 to 2.5 people for one individual infected, the Delta variant was 5 to 8 individuals, and 70 to 80% of household contacts are being infected. And usually that occurs within 5 days. And it should be kept in mind in all countries, 80 to 85% of all infections are contracted in the household in family clusters. Now, what about the Omicron? Well, guess what? Rather than 9 mutations, there are 50 mutations, 36 of which are in the spike protein. And this is an image from the NIH Vaccine Center showing the multiple sites. And it's twice as efficient at spreading as Delta. And as a consequence, it has a very high reproductive rate, which I'll show you. But let's look at these mutations a little bit more. Here in the binding site, remember that's where the ACE2 binds to the ACE2 receptors. Look at all the orange mutations in the Omicron. Virtually every single site is mutated, and it seems to have gained a tremendous advantage. And look at the furin cleavage site, which I told you is important. It has 4 mutations in that particular site. So this is really a super virus. And what does that mean? It means it binds the ACE2 receptors even stronger than the Delta. It enters cells more rapidly and efficiently, 70% more rapidly and more efficiently than the Delta. And finally, down at the bottom, the number of viral particles compared to the wild type, 7,000 more viral particles per cell. So the concentrations are tremendous in the saliva. So what does that mean? That means it spreads. The reproductive rate is 10 to 16. One person can infect 10 to 16 people. So if an infected person walks into the room, you're highly likely to be infected. And in households, it's highly likely almost 100% of those in the household will become infected. Now, let's look at what happens at first. In the first period of time, it's asymptomatic, the first 24, 48 hours. And there it's concentrating in the nasal pharynx. And unfortunately, because of the high concentration, 7,000 times higher than the original virus. The good news is it does grow in the bronchoepithelial cells, but it looks like preliminary evidence shows that there are lower growth rates in alveolar cells, cells within the lung itself. And we'll talk a little bit more about that later. But what this tells us is that you are going to spread by droplets and aerosol. And when it turns out that Delta and the Omicron, they spread predominantly by aerosol. That is very small particles, less than 5 to 10 microns, that stay in the surface out in the air for 3 to 4 hours and can migrate and fill a room, so that if you walk into, if someone has been sitting in a room for a prolonged period of time and you walk in, you will inhale that aerosol and you will become infected. So aerosol is a major, major way that this virus spreads. So what that means from a face mask standpoint is the cloth masks are virtually useless. Throw them out. The surgical masks are somewhat effective, but really the key is an N95 or a KN95 mask, which fits tightly around the face and has very tight pores to block the virus from you breathing it in. And the other key is ventilation, and outdoors. This is an indoor virus. Whenever you can, gather with people outdoors. The small rooms, bars and restaurants, gyms, very dangerous unless there's very high airflow. So that be careful of any closed public space. Now, what about the vaccine? We've heard a lot about the vaccines. How do they work? Well, we know that what they do is they bind, all the vaccines are directed against the spike protein, and they bind the knobs. They bind the spike proteins and block them from binding the ACE2 receptors. And so the vaccines see this part of the virus, the antigenic, and that's what they bind to. As you can see, there are multiple mutations in the antigen recognition site. So what does that translate to as far as the efficacy of the vaccines? Unfortunately, when it comes to J&J and AstraZeneca, which we don't have in this country, it does not protect at all. Zero protection from 2 doses of the AstraZeneca or 1 dose of the J&J. If you get a booster, you can increase, and this is this is Omicron as compared to Delta. You see there was some protection. Omicron, this is 0 right here, and it's basically no protection unless you get a booster. And if you get a booster, you get about a 75% efficacy. What about the Pfizer and Moderna is virtually identical. You can see that the Omicron also reduces efficacy to about 33%. If you get a third shot, we've been calling it the booster, then you improve the efficacy to about 75%. It's important to keep in mind that the studies do indicate that even if you've only gotten the 2 shots, you were protected from getting an infection, only 33%, but you have a 70% protection against hospitalization. If you get the booster, it's likely to be 100%. So we need masks, we need ventilation, we need to avoid large numbers of people, and most important, we need to all be vaccinated. Now, what do we know about illness severity? There's been a lot of talk about this. We know it grows more rapidly in the bronchial epithelial cells. That's why it's so infectious and gets into the saliva in high concentrations. A little lower growth rate in one preliminary study in the pulmonary cells deep in the lung, and that would suggest maybe a little less severity. The preliminary data suggests that the hospitalization rate is 35% as compared to the other variants, and reduces the rate of MICU admission down to 20%. In other words, a reduction of 80%. Now, these are only possible outcomes. Some in Great Britain, they're claiming it's equally as virulent. So we're hoping that it's less virulent. We really aren't sure. Now, what's going to happen in Florida? Well, I think today, if you saw the headlines in the Gainesville Sun and the front page, the EPI, Emerging Pathogen Institute, Ira Longini, Tom Hladish, and Alex Pelle have put together a simulation of what they think would happen, knowing the reproductive rate, knowing this, they're assuming, and they've been assuming a lower severity of illness. They come up with, first of all, there will be in mid-February, and actually I just talked to Ira Longini 20 minutes ago, he thinks it's going to be earlier. It's actually progressing more rapidly than they predicted. So it might be mid-January, but anyway, there is going to be a big peak of approximately 30,000 cases per day. That's per day. So that will accumulate to really millions of cases very quickly. And that's the number diagnosed. The number that are actually infected, because a number of people won't get the test and won't get it reported, he estimates 150,000 per day at peak. And as far as deaths go, the estimate is for the good case scenarios is 100 deaths per day. So what does that mean to our health system? Well, 100 deaths per day, and he estimates in some scenarios 600 per day, and it could even be higher. But if we know that in most medical intensive care units, the mortality of COVID-19, if you're in the MICU, is about 20%. That's a conservative estimate. That would mean if we have 100 deaths per day, that would mean 500 MICU admissions per day. We know that MICU, the average duration in the MICU is 10 days. That means at peak, at the most conservative estimate, 5,000 MICU beds will be occupied per day. That is 80% of all the ICU beds in the state of Florida, which has 6,195. If we say 200, 300, or 400, we will outstrip our MICU capacity by 3 to 4-fold. So to conclude, then, the Omicron is one of the most infectious agents ever. It's more rapid growth in cells and higher concentration of saliva. I explain this rapid transmission, and it's transmitted by aerosol, fine particles that stay in the air for prolonged periods. Therefore, air filtration and ventilation would be critical, including N95 and K95 masks. Full vaccination now equals 3 shots, not 2. And with 2 shots, you only get minimal protection. With the present COVID-19 friendly policies in Florida, Florida's health system will be overwhelmed by late January to mid-February. So the time to act is now, and that's why we're presenting this data. So I would submit to you, this is World War III. And the enemy is the Omicron variant and the Delta variant, COVID-19. And I encourage everyone to join the battle and get 3 shots.